accommodating, and thank you for coming here. I'm Baxter. For those of you who don't know me, I'm a family medicine physician. I am board certified family medicine. I did the Menopause Society. I'm a certified practitioner. I did the Heather Hirsch Academy certification, and then I've just kind of been obsessed with this topic for the last 6 years. So I've done a lot of self-study. I've been prescribing. Is there music?
Yes.
Is it in my head or? But I've been prescribing hormone therapy for about 6 years, and last year I actually left my practice in Jackson Hole, Wyoming to fully pursue this because there is such a massive gap in providers. And so I launched a telehealth company, and we're in several states, and the goal is to be able to reach women in like rural and urban communities. And telehealth is actually a very easy way of doing this type of treatment. And so it's been amazing, and I love it. And I appreciate you all coming here tonight. I love talking about this topic, and whether you're like before menopause, during, after, I hope that you can find some nuggets here tonight. I am going to talk about lifestyle and non-hormonal options a little bit, but I am going to talk a lot about hormone therapy because this is the area that people don't know about. And people don't know what their options are, and providers aren't trained in it, and so we're going to talk quite a bit about that tonight. Happy to answer any questions. I have some questions on my sheet that people sent in online, and then I don't know how long my talk will take, maybe a half hour, maybe a little longer, and then we'll open it up and happy to answer any questions. I also have like some examples of like what an estrogen patch looks like and different things up here that come up afterwards. And if you don't want anything that we handed you tonight, it's totally fine. Just put it back or give it to someone else. We can always reuse it. So basically, as an intro, like the reason we're all here tonight is because perimenopause and menopause have been ignored, misunderstood, and under-researched for the last several decades. In the early 2000s, a misinterpretation of the Women's Health Initiative study, which we will discuss tonight, caused hormone therapy prescriptions to plummet from over 50% to less than 5% of women, and it's at that level today. The impact of this Women's Health Initiative and how it was handled, regardless of whether or not women are on hormone therapy, is actually extremely far-reaching, and it's global. First off, this topic impacts half the population over the age of 40, sometimes younger. So that's 85 million women in the US. There's an impact to the woman who's been ignored while experiencing increased health risks and decreased quality of life. There's the economic impact from loss of productivity. So this is oftentimes women's prime earning years, and 1 in 10 women actually stop working within perimenopause and menopause due to symptoms. In the UK, it's 1 in 5. Plus, there's the loss of productivity from brain fog and cognitive function, going to doctor's visits, the other symptoms that can be debilitating. There's the increased medical visits. So studies show a woman on average will see 5 to 7 practitioners, so not visits, practitioners, before she's accurately diagnosed as perimenopause and given treatment options. What this means is they end up going in for palpitations, joint pain, brain fog, all these different things, and they're given, here's a prescription for your depression, here's a prescription for your palpitations, getting a big workup and a list of prescriptions. There's the loss of funding to research. So the Women's Health Initiative in the early 2000s, late 1990s, was a $1 billion study. That was the biggest study done in women's health. Since that time, that was by the NIH. Since that time, NIH funding actually fell to less than 1% where it's been at. In the last several years, it was still at 0.03%. The generations of medical providers, which is a hugely scary issue. They've done recent studies, these medical providers for 2.5 decades have not been educated on menopause and hormone therapy. They just did a study, less than 6% of your OBGYNs, your family med docs, your internal med docs, and others have had even an hour of training on the topic we're talking about tonight. So when you go and talk to someone else and they tell you hormone therapy is horrible, it's not for you, it's not okay, but you've read about it and you're like, I don't see it. I mean, I think I'm in perimenopause, I don't know. I would really question if that person's actually had training, either at all or in the last 25 years. So it is a topic that is incredibly important for a woman to actually do their own research right now and advocate for yourself and make sure that you're seeing somebody who has training. And it can at least discuss treatment options. So that's kind of the goal tonight, is I just want you to be educated about what's out there, what's available, who might be a candidate, and what questions to ask, and then kind of going forward, keep doing your research, and I'm here to support you if you ever want to talk. I do free discovery calls. You can just call me if you have questions. Totally open to it. If you want to see me, I'm available as well. There is good news here. So actually, as you probably all know, there's been a huge push in like social media and big stars coming out and really advocating for perimenopause and menopause awareness. There's actually a lot of legislation happening around this. They're actually making providers get trained in this now, and they're making insurance cover it, which you aren't covering it, like what? So there is, a movement happening, and it's wonderful, but it's like way too late. And a lot of people have been forgotten for a long time. So, first question, you don't have to raise your hand, but just thinking about kind of what we just talked about, people struggling to find an educated practitioner in perimenopause, menopause, options for hormone therapy. It's a very common problem. This is what we just talked about. So why do symptoms and health risks increase during perimenopause and menopause? So basically, perimenopause and menopause is a castration event. You literally go from having estrogen and progesterone since puberty to decreased egg supply, and because of the decreased egg supply, the brain is sending hormone signals and saying, come on, give me more estrogen, and instead it'll like overshoot and your estrogen's gonna go like way too high. So it might go up to like 1,500 estrogen, and then it might drop to like 5 overnight. So perimenopause is hormone chaos. This is this phase where you're just kind of out of whack, and this is why labs are not very helpful in perimenopause. A lot of people are like, come get your labs checked. That'd be fine if we had like a really good like hormone tracking. There are some, like you can pee on a stick, and sometimes like there are some tracking methods, but there isn't great tracking. It's very predictable based on symptoms. If you're having like bloating and then all of a sudden you have like a horrible migraine, you probably just have like an estrogen crash. There's a lot of predictable symptoms, and we know based on progesterone, estrogen, and the symptoms they cause if someone's in perimenopause or menopause, and we'll talk about that tonight. It's a clinical diagnosis. So by the time you get into this postmenopausal state, which I should define this, so menopause is, it's one day of your life, literally. Congratulations. It is the one day where it has been a year from your last period, from like natural means, not from being on birth control, obviously. It's a hard diagnosis because a lot of us are on birth control or have had a hysterectomy. It doesn't meet the clinical definition. The reason it's there is because once a woman goes through natural menopause, we don't want you to have vaginal bleeding again. And so for a clinician, we're like, oh, if you start bleeding again after menopause, like maybe I should screen you for uterine cancer. That's really what matters to us. When it comes to like the hormone therapy world, it doesn't matter. We can treat you with the different products we're gonna talk about tonight, regardless of if you're in perimenopause or menopause. There's just like a little nuance into how we treat the different symptoms. But the important thing is the postmenopausal state, there's no more estrogen and progesterone. That's why I say it's a castration event. For men, it would be, hey, like we're removing your testicles tomorrow. But enjoy it. Like,
well, let's just try that and see what happens. Did I say that out loud?
So that's estrogen and progesterone. It's gone. It's never coming back. Your levels are going to be 0. I don't need to check your level in menopause. It's going to be 0. Testosterone's a little bit different. So testosterone's made by the ovaries, but it's also made by the adrenal glands. The adrenal glands are going to then try to carry the weight, but you can imagine that your level's going to drop by at least 50%, and it starts dropping after age 30. So testosterone is a big deal for women. We actually have 10 times the amount of testosterone in our bodies as estrogen during our peak reproductive years. So it's not like a male hormone or a female hormone. We are highly impacted by testosterone as well. So when we talk about symptoms, you're not going to be able to read this, but this is like a lot for me, so I don't just ramble. Estrogen, progesterone, testosterone all cause different symptoms. The most common ones everybody knows about, the hot flashes, the night sweats, what else? So oftentimes progesterone actually falls first in perimenopause. So women start having problems with sleep, irritability. I hear a lot of like, I'm gonna kill my partner if you don't help me. And then you can start getting vaginal dryness. So estrogen, vaginal dryness, the period changes, spotting, changes in your cycle, it might become more frequent and then get further apart, could get more heavy. All of that is part of estrogen and progesterone changes. But it's everything else. There's cognitive function, so brain fog. People are like, my ADD got way worse. I'm having difficulty with word finding. It's hard to remember to like pick up my kid from school. There's the depression, anxiety, headaches, migraines, dizziness, like vertigo, ringing in your ears. There's a lot of weird symptoms. Skin changes, body odor changes, gut microbiome changes. Microbiome changes in the pelvic area as well, so a lot of like vaginitis, meaning like yeast infections or bacterial vaginosis, UTIs. That's actually because of a loss of estrogen to the pelvic area. That estrogen actually creates a pH balance in the bladder and the vaginal area, and changes in the pH balance are what causes women to have all those symptoms called genitourinary syndrome of menopause. That's like the increased UTIs, dryness, pain with penetration, pain with having a pelvic exam. UTIs, vaginitis, like I said. Osteoporosis, so your bones, there's like 8 ways that your bones are impacted by estrogen. So the best way we can build bones is by estrogen. When it's gone, we rapidly lose it. After menopause, you lose 30% of your collagen within 2 years, which impacts your joints, your cartilage, your tendons, your blood vessels. It's a lot of different things, your skin. That's quite a few of those. And then most common doctor's visits, fearing another diagnosis. So people come in and they're like, I think I have dementia. I think I'm having palpitations. These are all normal perimenopause symptoms. Joint pain. 50% of women actually have like arthritis and joint pain during perimenopause and menopause. Genitourinary syndrome of menopause we just talked about, and we'll talk about it more. There's a lot of health consequences associated with losing these hormones, and this is not to make everyone feel terrible, but like it's an important part of preventative health, so it's important to mention that your risk of osteoporosis goes up in fractures, risk of metabolic syndrome. What that means is it's a combination of weight gain, insulin resistance, so increased risk of diabetes, increased blood pressure, and then changes in your lipid panel, your cholesterol. Come on in. There aren't many chairs, but make yourself comfortable. Increased risk of cardiovascular disease. Estrogen actually plays a huge role on our blood vessels and dilation, so a lot of people get high blood pressure during perimenopause and menopause, and increased atherosclerosis and plaques. And then there's all the vaginal pelvic symptoms like we talked about, and then sadly increased risk of suicide as well, depression. Many other risks as well. These are like the major big risk factors that I talk to women about. So 1 in 2 women will actually have an osteoporotic fracture, 50% of people in here. A third of women after a hip fracture will die within a year, and 50% will end up with a cane or a walker. Osteoporosis is highly undervalued in our healthcare system. We don't even screen women for osteoporosis until 65 in the normal system. I screen people at 50 because I'd rather catch you before you develop it so that I can do something to prevent it. It's like $85. Maybe it's a little more in Jackson, but it's not an expensive test. And when it comes to your health, honestly, if you just wanted to pay out of pocket for it, you could do that, or call me and I'll order it for you. There's a lot we can do to prevent osteoporosis, but we're just not doing it. We're not catching it soon enough because people don't know this. 1 in 3 women will die of heart disease or stroke. That is the most likely reason women die in the US. 1 in 8 will get breast cancer. So it is common, it is common, but when later on we're gonna be talking about risks of hormone therapy and why we stopped prescribing it. It was over this like potential risk of breast cancer. That risk increase was 0.1% found in studies. That's why we stopped prescribing hormone therapy. So I just, like it's part of this, it's important, and I deeply care about women with breast cancer. In our clinic, we work with breast cancer survivors. I wanna take good care of them, but honestly, like get your mammogram before you start and do it every year. And you know, if it's something you want, then like don't let the breast cancer risk be the thing that scares you away. I gave you a handout on lifestyle. So when we think about preparing or perimenopause, menopause, the habits that we have now are really going to determine our long-term health. And this is the big things are, I know sleep becomes a huge problem. So making sure your sleep hygiene is really good. And then if you're using other sleep aids and you don't know if hormone therapy is right for you, progesterone is amazing at sleep. So it works really well in helping women sleep. The reason you're not sleeping is probably because of progesterone. So if you are a candidate, potentially there might be a helpful thing. Nutrition, increased protein intake is like the big take-home point here. If everybody just like tried to get enough protein, then you'd probably be so full from trying enough protein and fiber in your diet that you wouldn't like need to restrict things. I'm like pretty anti-restriction. I'd like to like add things. So it says on the sheet 0.8 to 1.2 grams per kilogram. You divide it out throughout the day. That's like a general rule of thumb. And of course, everybody's a little bit different. So if you've worked with somebody and they said this doesn't apply to you, that's okay. It might not. Strength training, I've had so many female patients be like, oh yeah, no, I don't do that anymore. That was something I did when I was a kid. Actually, strength training is probably one of the most important things we can do as women, and making sure that you go to a place where like, you haven't done it before, making sure you're doing it safely and you're learning how to do it properly. Like here at Wildfire, I know they do a great job, but it's something I'm like trying to get myself to do. I don't want to do it either, but it's really good for us. The reason is that we all start losing muscle actually after age 18. And it gets harder, it's way harder after menopause. So without hormones in your system, it's gonna be even harder. But I have on that list like creatine, protein, plus the strength training can all be keys if you can't have hormone therapy or with hormone therapy. And then alcohol is a really big one. Alcohol actually, there's no safe level. If you look on like the American Heart Association website, they're like, to be clear, we never said this was good for your heart. Like, one a day, and I'm like, good to go. That's like max. So it's like so ingrained in our culture. And I will go drink a glass of wine, and I don't poo-poo on it all the time, but actually, that's a huge way that you can really benefit, like your strength training, because alcohol actually impacts your ability to build muscle. So you actually can get really skinny arms and legs from from drinking too much, because it's actually blocking your ability to build muscle in your limbs.
Interesting.
Not to mention the cardiovascular, metabolic, other reasons why alcohol is unhealthy. And then like the social community support, I think having people you can talk to about perimenopause, menopause, a support system, people on your team, your care team being supportive of your goals is just so important. Stress and cortisol is really interesting. I don't always listen to Huberman Lab, and there might be like some antis here, but I think his episode on cortisol is pretty fascinating. Huberman Lab is like a podcast where he like biohacks longevity, and he can get like really nitty gritty. But the thing about perimenopause and menopause is your cortisol, we all naturally have this like spike and valley. So like when you get up in the morning, it's supposed to spike, and that's great, it gives you energy, and then it drops before bed, and then you kind of are able to go to sleep. But perimenopause, it actually shifts your cortisol spike and valley, and so women can have a lot of issues around cortisol levels that we can like biohack by like delaying your caffeine intake, grapefruit juice if you're not on a statin or other meds where you can't have that. There are ways of kind of manipulating that system in a more favorable manner so that you don't crash at 1 p.m. or 2 p.m. So there's ways of biohacking that system that's kind of interesting. If you ever want to nerd out on it, I'd love to talk about it. Non-hormonal options, that is kind of what like the Western medicine system has been doing for the last 25 years when we haven't been prescribing hormone therapy. So there probably are a lot of practitioners who are pretty comfortable in prescribing for this. The problem is that you don't have the like preventative health aspect of being on estrogen, but optimizing lifestyle, for sure, strength training and doing the lifestyle things can really help with menopausal symptoms and help with obviously longevity. So this is going to be great for you, the lifestyle part. Cognitive behavioral therapy and hypnosis have actually been shown to really help with symptoms. And then we have a lot of different treatment options and a lot of new treatment options for like low libido or for hot flashes. So there are more options out there today than there were a few years ago. But it's we definitely like will treat more based on symptoms. And we'll talk a little bit more about like age tonight too. So like the genitourinary syndrome of menopause treatment, we're gonna talk about this, is like fine for anyone at any age. So no matter what age you're coming in here for, like we'll talk about why hormones might still be a candidate for a lot of people who think that they're not a candidate. Hormone therapy and what should I use and for how long? So the goals are symptom improvement, improving quality of life, and reducing risk of chronic disease. Hormone therapy is going to treat like pretty much all the symptoms that we talked about. Our goal is generally like an 80% improvement when you start hormone therapy for all the symptoms that we mentioned before. But it's also going to help with like preventing the weight gain, the cartilage loss, the bone loss, the cardiovascular risk, and you get more benefits the earlier you start. So that's another theme here as well that we'll talk more about. So if you start hormone therapy closer to menopause, it's going to be more helpful that you're like continuing estrogen and progesterone than if you start it later, but it doesn't mean it's like not an option. Skin, hair, vaginal and sexual health, sleep, there's a lot of different benefits. If you have a uterus and you want to start hormone therapy, you do need to be on both estrogen and progesterone. If you don't have a uterus, then you can be on just estrogen, and we would add progesterone if you want for symptoms or if you want to try it. I commonly end up adding it because most people have problems with sleep or mood. And so that's optional, but oftentimes beneficial. Testosterone, currently the only indication is for postmenopausal low libido. But as we talked about, testosterone actually starts decreasing in our 30s. So a lot of people benefit from it earlier, and there's a lot of other benefits too. So when in cognitive health, people are oftentimes like, oh, I just still didn't feel like myself until I started this. Some people say it's like the cherry on top, or they just kind of like feel like themselves again. Pelvic health and pelvic pain, there's actually a lot of testosterone receptors around the vaginal opening by the urethra. So sometimes we find that a vaginal DHEA product, which is both estrogen and testosterone, works better than estrogen alone. So there's a few different reasons why we might add testosterone. Fatigue, energy, there can be other reasons too. And then there's systemic versus local. So some of the products we would give as, like, I'm gonna talk through those, but we would give as like a patch or a pill, and those would be, or gel, those are gonna like saturate the whole body. So you're gonna be working on bone health, cognitive health, preventative health with a systemic version of hormones versus a local is going to be like just the vaginal products. Generally, those aren't absorbed and they don't do any of the preventative health, but they work great for genitourinary syndrome of menopause and kind of like the local action for the urethra, the bladder, the vulvar tissue, and the vagina. So we'll break that down a little bit. As far as starting hormone therapy, someone asked this question online, is there a reason to start before having symptoms? I can think of a few cases why we might, and the big ones are, we have a lot of people who over-exercise in this community, and if that can be fun, but if you're somebody who's over-exercising and you stop having a period by natural means, that actually is concerning, and one of the biggest concerns about that, there's many reasons. We actually have an expert in this room, Eden Morris, over here. She's raising her hand. She's an eating disorder specialist. She's an amazing resource. But we actually don't have estrogen levels, and you lose your bone density. So women get osteoporosis in their 30s and start having fractures. That would be a reason to give hormone therapy early. But oftentimes, I would say, women are like on birth control and they might switch over to like a menopausal hormone therapy around menopause, and we'll talk about the difference there. But if you're having like perimenopausal symptoms, you're noticing your sleep's changing, you're noticing your periods are changing, hot flashes, anything, it could be like one little thing, you're welcome to start hormone therapy. Oftentimes, perimenopause is about 7 to 10 years before official menopause happens. So it can be many years, and if you start early, say like your late 30s, and you have severe symptoms, it's possible you're gonna have severe symptoms for 15 years. So something to consider. Go ahead.
Just want to reiterate that oral contraceptives are not the same thing HRT, and if you don't have a period without oral contraceptives, they will not jumpstart your period.
Yeah, so HRT, hormone replacement therapy, it's a little bit nuanced. People use it interchangeably socially. Hormone replacement therapy is technically giving someone normal, like high doses at a young age. Hormone therapy, menopausal hormone therapy is actually like a really low dose, but for the purposes of tonight and like what you guys need to worry about, I'm gonna go into like, so synthetic hormones are like your birth controls. They're all synthetic. They're not necessarily bad, like they can do a ton of good, and some people don't want to use them and they have a lot of symptoms, and that's because they're not quite the same hormone that your body makes naturally. Bioidentical means it's the same hormone your body makes. So the bioidenticals tend to have better symptom relief, and even in perimenopause we'll start bioidentical hormone therapy sometimes, versus the synthetics. They work better for like bleeding control. So if you're in perimenopause and you're having heavy bleeding, frequent spotting, putting you on a synthetic might be a really good idea. And then we could like add a little bioidentical as well. Versus if you're like menopausal or your period's like almost gone, we'll probably, at least my practice would be like always go towards the bioidentical option because it's safer. And we'll talk about that. So bioidentical, the names are going to be estradiol, micronized progesterone. So if your prescription says progesterone at all on it, that means it's actually progesterone, versus like levonorgestrel or norepinephrine. Those are progestins, so they're a synthetic version of progesterone, but they're not the bioidenticals. And then testosterone's also like bioidentical. And there's a lot of different types. I have a few of them here. I have like what a patch looks like. They're actually like teeny tiny. The twice weekly patch is about that big, and you just like put it on your skin. I have like a mist. I have a gel. You guys can come look at if you want. There's a lot of different ways of taking estradiol. There's a pill. Micronized progesterone just comes in a pill form, and then testosterone is generally a gel form. The other caveat about testosterone is there isn't a female FDA-approved product, even though we've been giving it to women for decades and decades and decades, and we have a lot of studies showing its safety. The FDA hasn't created a product yet. There is one in several other countries, but here we use the male product, but we dose it for women, so you use 1/10 of the daily dose. So I have one of those products here. So this little tube, like a male would put the whole thing on their skin, a woman, this would take about 7 to 10 days to go through. So it's not a big deal, but we're getting there. People are fighting for it. And then back to those were the systemic versions. This is the local, so going back to the vaginal products, we have the estradiol cream. There's going to be tablets, inserts. Some of them are like these little tablets. This is the DHEA product, so it's estrogen and progesterone, and it's a little insert. And this is to treat the genitourinary syndrome of menopause. And literally, you can start this. I just started this on my 93-year-old grandmother. It's safe at any age. I have another slide on this, but these products are awesome and should never be stopped. Going into that, the risks of hormone therapy. So the low dose local vaginal estrogen. Every woman will develop genitourinary syndrome of menopause, whether they have a lot of bothersome symptoms or not. Very much depends, but this is like the dryness, the UTIs, the vaginal infections, the tissue will actually get thinner, the labia minora will reabsorb for some of them, and there's varying degrees of severity, for sure. But basically any woman can have this. There's no evidence linking it to blood clots, stroke, heart attacks, breast cancer, but on the label you will see this, on the FDA label. And this is because of the Women's Health Initiative study. I have one more slide on that in here just a second. They are fighting the FDA like crazy right now to try to get this removed because this medication saves lives. Dr. Rachel Rubin, who's this amazing urologist who does a lot of hormone therapy education, she did a study and she's found that if we put every woman on Medicare on vaginal estrogen, it would save Medicare between $6 and $22 billion a year.
Oh my gosh.
Because this is huge. Genital urinary syndrome menopause is a huge problem. The costs of going in for urine cultures. These women are getting sometimes UTIs every month. They're dying of urosepsis in our hospitals from a product that is safer than ibuprofen. We have huge studies showing that it doesn't, in a woman with hormone-sensitive breast cancer, did not increase risk of reoccurrence and improved quality of life, and they lived longer. So I will talk to anyone's oncologist. What maybe like when you're in the throes of it right at the beginning, this might be something they don't want to do, but generally, if you're on the low dose, which is like a twice weekly version of this, we have a lot of studies, it doesn't actually get absorbed systemically. It doesn't change your blood hormone levels, so it's generally really safe. And there are some other, the DHEA, there's like other products as well that work really great for this. It's awesome. Vaginal moisturizers and lubricants are great, and they should be used for sure, awesome, but they don't treat the like infectious, the scary part of this. They don't prevent the tissue changes. A lot of women can't even get pap smears anymore from this, and this is just like a very easy thing to treat. And we do like really cheap, quick consults on in our practice for this. Like you can put anyone on the phone with me, and I'm happy to discuss the risks with them and get them started. The Women's Health Initiative, I mentioned this a few times. So this was the late 1990s. This was the billion-dollar study I mentioned. There was two arms of it. There was women on Premarin, because now you know the women with the uterus had to be on an estrogen plus progesterone. So this is synthetic hormones, Premarin and medroxyprogesterone, both of which I've never prescribed. We don't really use these products today, or Premarin only if they didn't have a uterus. And they stopped the study within 5 years because they said, oh my gosh, this causes breast cancer, we're hurting women. They said there was like a 24% increased risk of breast cancer. This is not true. This is relative risk. So relative risk is hard to understand. What you need to actually know is absolute risk. And absolute risk it was an increased risk of 0.1%. And so there has been 25 years of people bashing the study and being like, there are really good things that happen with the study, but people being like, that is not true. You put it all over the news. They had like a press release. It's very unusual that something like that would happen. So they basically cut off the study. They also saw increased risk of blood clots, which is true. So oral estrogen does increase your risk of blood clots, as people probably know from taking like birth control pills. So that's why we have like a lot of skin transdermal products. And then the study also showed that in that group, it reduced the risk of dying from any cause. So even though there was like this slight increased risk of breast cancer, the women didn't die from they had less likely to die from it. Way reduced risk of fractures, way reduced risk of diabetes. And then in the Premarin only arm, which is the estrogen only arm, there was an increased risk of blood clots, but they actually had a reduced risk of breast cancer. So they're on estrogen, reduced risk of fractures, diabetes, all cancer, all dying of any cause. But none of that was like published, like was put out into the media. So that's why people stopped prescribing hormone therapy. They also said with the increased cardiovascular risk, this study was done on, the average age was 63 years old. There was 21% of people in the study were over the age of 70, and they were starting them 20 years later on hormone therapy, basically kind of similar to like a birth control pill. So that's not something I would do today, but like it used to be kind of a normal thing to do. They actually did find that if you started it 20 years after menopause, if you started these two products, it did increase your risk of blood clots, stroke, heart attacks. Go ahead.
I'm just curious, you haven't mentioned anything about GYN cancers.
Yeah, it doesn't, so hormone therapy doesn't increase your risk of endometrial cancer. It actually can reduce it. And part of that is with the fluctuations in perimenopause, you can actually have like a buildup of the endometrium. Anyway. And then ovarian cancer, is that what you're talking about?
Yeah.
Yeah, it doesn't show increased risk, and in fact it shows decreased risk in people who are like BRCA positives. That's like a type of genetic mutation where you have like an 80% risk of breast cancer. We frequently put those women on birth control to reduce ovarian cancer risk. And we put them on hormone therapy after we remove their ovaries as well. And then women who were 10 to 20 years from menopause, there wasn't like really a risk of putting them on it, but there wasn't really a big benefit in cardiovascular disease. And then less than 10 years from menopause, it actually significantly, like over 30% reduced the risk of cardiovascular disease. And none of this was in the news. And people today still don't know this, that you have to like stratify this out by age. So we basically think that by giving women continuing estrogen from a time when you have it, just continuing it on, it's very protective, and you can continue that forever. In fact, if we stop hormone therapy, rates of heart attacks go up within the first year significantly. The problem potentially is putting someone on like a synthetic oral estrogen, progesterone, when they're like 20 years out, which there are safer options, and I'll mention those. Those are like the transdermal patch, gel, spray, estrogen. They don't have the same risk, which I have a slide on, sorry.
Can I ask a question about testosterone? It wasn't in the women's health study.
No.
Does it increase risk of liver stroke?
No.
Not at all.
No, in fact, they just did the Traverse trial on men, so we need more research on women, but they've done some big studies on testosterone in women. But it used to be on the labeling for men that it increased risk of cardiovascular disease, and they're like, oh, I think there's a problem with this. They put this big trial in place and they removed the label within 5 years because it doesn't increase risk of cardiovascular disease or stroke. In fact, it like improves that risk for men generally. So they haven't found that in women either. And then, so breast cancer risk summary, synthetic hormones, there might be a potential slight increased risk, 0.1%. In some trials, they didn't find that. So there's like some that don't show increased risk, some they do. So I would say, in abundance of caution, most of us don't do synthetic hormones forever. We would do bioidenticals. There's no known increased risk based on trials on bioidentical hormone therapy. The thing is that hormones are fertilizer for certain types of breast cancer. If you have an estrogen-sensitive breast cancer, progesterone-sensitive breast cancer, it will cause it to grow. So I always make people get a mammogram, or recommend highly, people get a mammogram before starting hormone therapy and then every year. And I know some of the guidelines have been like, you can do it every 2 years. I don't generally recommend that. Go ahead.
I was reading in your handout about collagen, and I heard that collagen can decrease the risk of cancers growing, but needs it.
I'm not super familiar with the data, but I will look into that again. Yeah. I think like peptides also, there's like quite a few things that like you're like nurturing a cancer cell. So yeah. And then family history. So say your mother had breast cancer, say you are genetically testing positive for like BRCA or other high-risk genes. It doesn't mean that you're not a candidate for hormone therapy. You just need to talk to an educated provider about it and get your screenings. Like I said, we give hormone therapy to women with BRCA. That's your highest risk of breast cancer. It's a BRCA mutation, 80% risk of having breast cancer in your life. We will still give those women hormone therapy. And the idea is that like your risk is already 80%, so adding like 0.1% potential risk to that, like do aggressive screenings, like you could do an MRI and you do like a mammogram every so often, like it's like way more strict. So do that plus, like if this is something you want to do, it doesn't mean it's a no.
What happens if you had breast cancer?
So within 5 years of breast cancer, it depends on the type. It's very complicated. So it depends on the type, if it's hormone sensitive or not, how advanced it is. We have like really high-tech calculators that help us guide patients on this. And then we work with oncology teams. But outside of 5 years, if people have been in remission that long, it is very common practice, depending on the type of breast cancer. If the mastectomy is done, there's a lot of factors, but it's common that women will be allowed to have hormone therapy again.
Huh.
And certainly vaginal estrogen might be an option throughout. Blood clot stroke risk. So that study also showed an increased blood clot stroke risk. With oral synthetic estrogens, it's 9 out of 1,000 women over the age of 50 could have a blood clot. When you do body identical, bioidentical, it's 1 in 1,000. And when you do a transdermal estrogen, it's no increased risk. So we actually give this to women who've had blood clots before, If you have factor V Leiden, it's actually approved in the the UK for using transdermal estrogen. That's like a higher blood clot risk genetically. So, yeah. It's just to say that like a lot of these risks, while like I appreciate them, they've been really blown out of proportion. It doesn't mean that like no one here has the option of doing hormone therapy. Hormone therapy is the FDA-approved first-line treatment for these hot flashes, because that's all the research cares about. Apparently that's the only symptom that matters. But it's easy to like monitor, so you can like give someone a treatment and you're like, oh, it works. Osteoporosis prevention, so like most women meet FDA approved criteria for osteoporosis prevention. Genitourinary syndrome of menopause, first-line treatment. It used to be like use lubricants first. It's not that way anymore. They changed all the guidelines this year. And then if you have menopause before the age of 40, so like surgical menopause, if you had to have your ovaries removed, like we know from the data that that like significantly increases your risks if you're not put on hormone therapy. And we do it all the time without like the blink of an eye. So it's definitely indicated for that as well. And the take-home points, I just want people to know about is the vast majority of women are candidates for hormone therapy if they're interested. They're safe hormone therapies, and that they're typically covered by insurance. Like everything I have here, I have lists of copay cards and things you can do, but it's generally not that expensive. And then every woman, basically I just want them to be educated and know that there are options for them, and whether you choose to do it or not, totally up to you. You don't have to do this, but just know that if you're getting a no, come talk to somebody who's had some education in this, and we can really discuss if it's an option or not for you. There's some new patients. Okay, real quick so I don't forget, online questions and then I'll open it up. Someone said that they developed food allergies and intolerances and severe allergies during the perimenopause, menopause time. It's a really interesting thing. So there's a lot of shifts that happen because of changing estrogen levels. The big fluctuations actually cause increased histamine response, and you can have stronger allergic reactions. Mast cell activation syndrome is way more common than we think it is, but that is exacerbated as well. And that's basically a combination of people will have like random like flushing, hives, GI issues, and it's like inflammatory response in the body, but just know that like it's the estrogen fluctuations that worsen that, and that progesterone actually dampens that and can decrease that histamine response and improve allergies. So you trying to like regulate someone's system so they're not having the big fluctuations, and adding progesterone can oftentimes help with allergies and intolerances. The gut microbiome, the bladder microbiome all change because of the estrogen and progesterone levels. So then a lot of like slightly different, but like GI intolerances, people will be like, I used to be fine, now I'm getting diarrhea all the time, or getting a lot of bloating. A lot of that is hormonal shifts as well. Someone asked about if we do labs to determine if somebody's hormone levels are appropriate. There needs to be a lot more research on this, but one example is, say I'm giving somebody transdermal estrogen, and the biggest concern for them is bone health. Getting their estrogen to a certain level, there actually are studies on that, will help with bone health more than if, like, say they're not really absorbing it, so they're like, their estrogen is like 10, getting them closer to like 30 to 50 might help. So sometimes lab testing is indicated, but like in our practice, it's individualized, whether we don't order like really robust, big lab panels. It's just like not my training. And some people would prefer that, and that's okay. There are people that do that. In perimenopause, like I said, your hormones are just different every single day. So I find it leads to a lot of gaslighting, because people will be like, oh, I got my hormones tested and they told me they were fine, or they told me my estrogen was high, so I must not be in perimenopause. It's like, no, of course you're in perimenopause. Your hormones are doing this all the time, so there are days they're gonna be normal and low and high. So lab testing is just kind of like an individualized approach. Someone else asked about energy levels, that they're cycling more frequently and they're having crashing energy levels before their menstrual cycle. Super common, because both your estrogen and progesterone are going to their bottom level right before your cycle. So because there's such higher highs and lower lows during perimenopause, you can have like much stronger symptoms of PMS and fatigue and exercise intolerance, and you can replace hormones and make that better. It's an option if people want to do that. And then making sure the lifestyle's ideal, like not drinking around those days, making sure you're having enough protein, making sure that your nutrition's in check, and that you're sleeping well will help as well. Tendon and joint health. Hormone therapy is huge, like I said, about preventing collagen loss. Bioactive collagen peptides, generally, you know, there are some studies showing that they can help with muscles, bones, joints. So, you know, there are some things that are on that sheet to consider. But basically, there are things you can do.
Can you rebuild what you've lost if you start hormone therapy?
In which thing?
Collagen,
Bones or what?
Yeah, that's what you can.
You know, I think it would be a little more nuanced than that. Like if it's been 20 years, certainly you can have more gains, and we see like dramatic improvements in bone density. And people say that like they're gaining more muscle and like studies show it and everything, but the closer, once again, the benefits are higher. Like the closer you start, but it's not a no. Like there isn't like, if you're 60, you can never have hormones again. That cutoff, it's, some providers might be more comfortable with that, but like in the literature, we would just go for like the safest regimen. We'd make sure you didn't have any like strict reasons why you couldn't have it, like you actively have hormone-sensitive breast cancer. There are some other things as well, but as long as you know the risks, the benefits, and that's something you choose, then we would oftentimes help people with like the safest possible regimen, and oftentimes like start really slow and low if you haven't had hormone in your body for a long time. We do like a transdermal bioidentical estrogen and a progesterone at like a very low dose. But yeah, there are potential gains for sure. And yeah, I think I got most of those, so I would love to open it up. Yeah.
I was just gonna ask, can you speak a little bit to like progesterone intolerance and what those symptoms are?
So micronized progesterone, which is the body identical version of progesterone, a third of women love it. A third of women are like, meh, I think it's like fine, but I don't know if I think it's hugely beneficial. And a third of people actually have an intolerance to it. Part of the problem is it's made in peanut oil. So, gotta love it, gotta love it. So if you have a peanut allergy, you can't have it, but some people still don't tolerate it because of that, and have had success with switching to compounded forms. But then other people are just highly sensitive to progesterone. There are cases of people having severe depression from micronized progesterone, so whenever I start it, I always tell people like just keep an eye on it. If you feel like you're getting depressed, then like this might not be an option for you. Other women get a lot of bloating, which bloating is common when you first start progesterone, but it tends to get better. But some women like will just like retain a lot of water. And I'd say those would be like the most common symptoms, but there could be others. Yeah. Go ahead.
Can you speak a little bit about increased migraines with estrogen? And is there any hormones that you recommend for people who suffer from migraines that are better than others as far as estrogen?
Yeah, so are you speaking, so like the common thing is the menstrual migraine gets a lot worse. So it's typically like the estrogen dropping, and because you're getting such higher levels in perimenopause, the drop will trigger more migraines for women. I don't know if migraines with aura is kind of like, it's always like you can never have birth control. When it comes to like bioidentical hormone therapy, it's totally fine. We give hormone therapy all the time for that because it doesn't increase your risk of blood clots. So we typically do like a transdermal estrogen, bioidentical before synthetic tends to work a little bit better. But I have found sometimes I'll do a synthetic hormone mix just to get someone to stop cycling if it is like a menstrual migraine. If we want to like get them to stop, then we do like a low dose progestin only birth control plus add a bioidentical estrogen, and sometimes that works. But it's a little nuanced because people's migraine triggers can be very different. But there are definitely options to help people with migraines. Questions?
What are your thoughts on progesterone cream?
It doesn't work that well. Not effective. The problem is progesterone's not well absorbed no matter what. Like pill either, and the goal is to protect the uterus, the cream oftentimes isn't enough. It also doesn't help with symptoms like poor sleep, anxiety. So I would say I tend not to do it. A reason why I might do it is if someone was like super sensitive and they didn't have a uterus, then we like could consider that. But I would be worried that they wouldn't get enough to like do endometrial protection from a progesterone cream. Generally. Go ahead.
Can hormone replacement also help with that insulin resistance that you
Yeah,
talked about?
hugely.
earlier?
Yeah, dramatically decreases risk of diabetes and very huge in preventing the metabolic syndrome, the weight gain, the cholesterol. It will improve your cholesterol. It reduces blood pressure, reduces insulin resistance and diabetes.
Just two things, just to clarify, that oral estrogen better for bones versus transdermal?
No. I would say it would depend more on your serum levels. So some people don't absorb very well through the skin. So technically, if we're looking at like bone protection, we would want your estrogen to be at least in the like 30 to 50 range. And I'm talking about like a postmenopausal woman on labs. And so sometimes when we do transdermal, people don't absorb as well. So I will frequently check and make sure that they're in that range to make sure we have good bone penetration. But if you have like a blood serum level in that range, we very frequently just do transdermal and it works fine.
Okay.
But
Then my second question is regarding the testosterone, is that an off-label use for that testosterone? This isn't
Yeah.
just like
always
compounded?
gonna be off-label because there's no FDA approved product.
So how about compounded?
You can get it compounded or you can get it through the pharmacy off-label, which basically just means it's not gonna be like covered by insurance. It's not like indicated by the FDA because they don't have like a product for you. But using meds off-label for menopause has been like what we've been doing for the last 25 years. We've been doing like antidepressants for menopause for 25 years. That's an off-label indication. If I were to like say you're having like horrible brain fog and joint pain and different periods and mood changes, and I use hormone therapy, that's all off-label, unless I put like preventing osteoporosis. But we're generally like if someone tells you like it's an off-label indication when it comes to like testosterone, like this is an FDA issue, not that we don't think it's like safe for women. We've been doing it for a really long time. Oh, yeah, Karen, I'll come back to you.
Okay, so I listened to Dr. Rubin
Yeah.
talk on one of her podcasts, well, a podcast she did. And, she was saying taking the oral estradiol. She mentioned doing it translingual as a way of avoiding,
First pass metabolism.
yeah,
Yeah,
what are your,
Yeah, you could
heard
do that.
anything more?
no, you could do that. Basically what she's talking about is the reason the blood clot risk exists with estrogen is when we take estrogen orally, it goes through the liver, and the liver, it increases inflammatory products, and it also that's what increases your blood clot risk. If you were to do a product through the tongue, the nose, through the vagina, through the skin, it doesn't do that. So it doesn't increase your risk of blood clots because it avoids the liver metabolism.
And was there improved results?
I've never done
Yeah.
that, but yeah, that's an interesting, like, a reason why I can see why I might do that is, say that someone's like super concerned about cost, or they have a bunch of the pills and they wanna use them, but they're scared of the blood clot risk, then you could say, sure, it probably isn't gonna taste bad, but you could dissolve it under your tongue. And then we could always like check serum level and see where someone's at if we wanted to. But yeah, that is another way we could do that.
Just gonna ask a last question. Some providers, they sort of automatically check FSH and is it luteinizing? And then they're like, oh, you're fine.
Yeah.
So what, just throw all of that out. Is it, like, what's your position on those labs?
So lab testing, if someone knows what they're doing, can be fine. I mean, a lot of people are data people, and they're like, no, I just wanna know what my lab's doing, that's
Yeah.
fine. You know, but the problem is people going and getting labs with somebody who doesn't have a lot of training in this. What they're checking for is, when your estrogen is really low, it's gonna cause a big spike in the FSH and LH hormones. And LH, luteinizing hormone, and follicle stimulating hormone are coming from the brain to tell the ovary, like, there's not enough estrogen, like, release an egg, and so it'll like spike up because your estrogen's low. And so technically you could like diagnose menopause by checking labs on someone, say like you don't have a uterus anymore. So you're not bleeding, you're like, I don't know, am I in menopause or not? I'm not on anything. We could check an FSH and it would be high, it would probably be like closer to 100 or higher. And then we could check an estrogen and probably like 0. And you'd be like, yeah, you're in menopause. And in perimenopause though, every day of the cycle your hormones are different. So if they're not careful, and if like say your cycle's a little irregular, it just becomes nuanced in finding the exact day that your FSH spikes and your estrogen. It's just like, it's a way to check for menopause. It's not that helpful in perimenopause.
So that, the FSH has the same fluctuations that.
Yeah, if you look at the menstrual cycle, it'll like spike right around ovulation, FSH and LH, and then you have a big estrogen spike, and then like the 2 weeks after ovulation, that's like when people like feel great and then like their libido's better, but like in perimenopause it goes too high and then you get like bloating and you get like really irritable. And then the next 2 weeks before your period is more when like progesterone will go up as high as it'll go, estrogen will go up a little bit but not that high, and then it all like crashes right before your period. And then during your period it's low again. But it helps to like actually look at a diagram of that, and I just Google the menstrual cycle, and it can be helpful. You can be like, oh yeah, when it's this time of the month I do feel like this. Any other questions?
So for women who are still regularly menstruating and have natural hormone fluctuations, is there a predictable way that the estrogen affects the cycle? Or is it just like taking continuous OCP, does it suppress the cycle?
Yeah. Like if you're taking a continuous oral contraceptive pill, is that what you're asking?
Is it like, if you were to take HRT, the estrogen with HRT, would it be similar to like taking continuous oral contraceptives?
No, so the bioidenticals don't suppress ovulation, so you'll still cycle. And the reason why we might use it is instead of having like the crashes, and like you'll have spikes, there's like a couple days in the month you're gonna have a high estrogen level, but we're trying to like build up your baseline a little bit higher so you don't crash and have the really low estrogen level. And then progesterone it's cycling too, but it's like just getting lower and lower, so we add a little bit of progesterone to help as well, but you'll still ovulate and you'll still cycle. And sometimes that's a problem, and because the bioidentical progesterone doesn't help with bleeding that much, like I said, the synthetics work a lot better for bleeding control and ovulation. It's fairly common in perimenopause that I'll recommend like a synthetic progesterone to suppress ovulation so you stop having the spikes. If someone's open to it, it also makes you stop bleeding and having a period. Otherwise, women can bleed a lot on bioidentical hormone therapy in perimenopause. Like I've had women where they're like, I had a period 5 days ago and now I have another one 3 days from now, and it can become like really annoying. IUDs can be really nice during perimenopause as well, and even though there is like a little more risk with synthetic hormones during perimenopause, I think a lot of times for quality of life, women choose that. And then you can, like if you have an IUD, I could add in like a transdermal estrogen, I could add in a little micronized progesterone, it makes things easier. So you can kind of like mix and match. And in perimenopause, I'll frequently have people on multiple different products that they can mix and match throughout the month. I give them like a toolkit because your symptoms change so much day to day. Does that help?
Yeah, thank you.
So if a provider doesn't code one of those 4 things, for HRT, then are you paying out of pocket? Does insurance not cover it then, or what's
The diagnosis codes suck. So it's literally like perimenopause, and menopause, like climacteric state. Like, you're like, what the heck is that? But you can do like, potentially, like I would probably do that code, or I do like prevention of osteoporosis just to make sure that it was covered.
Okay.
Yeah.
I should call it Mary Cause, because that list of symptoms was depressing. Just change the name.
And it's so different person to person. So some people, I think it's important to run through them. It's extensive, but like we get so many people who are like, have atypical symptoms like paresthesias. I'm having like tingling in my limbs. Like they end up getting an MRI of their brain and their spine. And if you gave them like sure, like of course I'm gonna check your thyroid. I'm gonna check other things. If I feel like that's indicated, if you need a musculoskeletal workup, if you having an abnormal heartbeat, like I should be working these things up, but like, if it's like, wow, my heart like races when I have a hot flash, that is probably from your hormones, and you probably don't need like a monitor today. You're not like passing out when it happens, you know, so, yeah. Any other questions?
All
No?
I can say is please continue pushing to get the world to understand and go through this. I'm so benefited by hormones, it's unreal. And I did a little practice, not at my choice. And I started decreasing my hormones in May, and it was horrible. My summer has been horrible.
Yeah.
And I have now increased them back up, and I am happy as a clam.
So you don't like have to stop it after 10 years. That guideline,
Right.
the Menopause Society got rid of that guideline over like about a decade ago. But like if you Googled it right now, it's so funny because I Google things just to like see. I'm like, what does it say for this? And it is so wrong. There's so many things that like there's a lot of misinformation out there. I have some like resources if you wanna come take a photo. I don't know where it went actually. Oh, here it is. You can take a photo. These are just some like wonderful people that I follow. I just think it's important to like have good education. There's some like good podcasts on here. Rachel Rubin, Mary Claire Haber, Heather Hirsch, Kelly Casperson. You can take a photo, but there's just a lot of misinformation, so be careful what you Google. And if you get an answer and you're like confused by it, feel free to call me. I won't charge, just to kind of talk. I'm happy to help.
Well, and I did a free session